Okay, so we're going to go ahead and get started here with the first of our theme conversations. Just to remind everyone how this is going to go is we're going to call up all of the speakers within a theme to come sit up at the front of the room. We're then going to have the mic and the clicker, which we're going to pass off between all of the talks. There will be a brief introduction, followed by 3 or 4 talks, and then time for a moderated discussion. The timer will be set up here between each of the talks so that you'll be able to see how much time you have from the 5 minutes counting down. And we can also make sure that you can see how much time for the 40 minutes discussion that we have available. So with that, I will turn it over to the first theme one. If you guys want to come up here and take your seats, we'll go ahead and get started.
Excellent. Okay, so it's my, is this on? Yeah? It's my job to introduce this session. Part of the mission of the NIH is to improve the health of the nation. I think we'd all agree that there are important contributions from all parts of the biomedical enterprise to achieving that goal. But I will assert that the theme that we're going to start with is perhaps the pointed end of the stick, which is to create systems to integrate genomics into everyday clinical and public health practice. The questions that we'll be addressing are what is needed to use genomics medicine in health, and they include creating systems to connect genomics to point-of-care clinical decisions, leveraging broad genomic data rather than individual genes and variants to routine medical care, and supporting iterative use of genomics as a lifetime healthcare resource, which is something that we've already discussed. We're very fortunate today to have Mike Murray, Denise Dillard, Casey Overby Taylor, and Latrice Landry to give focused talks about this topic. We'll go through allowing each one of the speakers to give a 5-minute presentation without interruption, and then we'll have some time at the end to discuss the topics. So without any further ado.
Okay. Well, thanks very much to the NHGRI organizers for giving me a chance to share my idea and to start off the lightning rounds. So my idea regarding creating systems to integrate genomics into everyday clinical and public health practice is to create a sustained framework and infrastructure to advance knowledge and implement care. And in this vision, I have that these are the participating units, so it would be state-based participation. And the idea is to, sorry, the animation's not working here, to create a network of statewide genomic medicine learning health systems. And the required components, as I've imagined this, for each one of those units would be the usual suspects here. So genomic medicine researchers and large healthcare systems. But it's important to note that these both have sort of a defined reach. And in particular, large healthcare systems exist within a competitive environment, and they are not seen as neutral by other large healthcare systems, particularly within their states. And so to address that, I think that including and requiring statewide institutions that have a mandate and have legislation and regulations behind them to integrate care across the whole state would be useful to this. For those of you who are not familiar with the Health Information Exchange, these are a result of over $500 million investment by the federal government over the last decade. And their mandate is to move information between health systems and health providers. And they can also message both. The other required element that I would suggest is federally qualified health centers. You may be familiar, there are about 1,400 of these across the country. They are in every state. And their mandate is to serve the underserved. And they have expertise and experience in that area, and I think that's critical as we think about these units as not only reaching those that are at large healthcare systems, but the entire population of the state. Of course, we also have to include patients and communities. There's lots of people with experience there, so I'll be interested in the conversation around that. We were asked sort of why hasn't your idea already taken hold. I think that there are 4 important precedents that I would point to related to this idea that we could learn from. First, of course, is the collaborative research networks that NHGRI has been launching and running for a decade or two, which there's lots of experience in the room around. The second I would point to is newborn screening, which evolved in a state-by-state model. And this may be hard to see, but this is how it marched out from 1962 until 1985, starting in Massachusetts, first as the PKU screening, and eventually being adopted across every state and territory in the District of Columbia. So I would imagine that early phase states in this sort of a network would be enticed by the funding and the infrastructure to really work together in this forced relationship with these required components in ways that they have not done before. And I think the innovative and collaborative teams from each state would come forward first and define sort of how the network is running. Later stage participation, hopefully it's in less than 22 years, but those would be able to plug into a ready-made and working system. 2 other relevant precedents: the AIDS clinical trial units launched by the NIAID in the mid-'80s and continuing till today have been sustained over that duration. And I had the opportunity in the 1990s to participate as an AIDS provider and AIDS researcher. And the 1990s in particular was a decade in which we went from telling people that, that we were essentially going to manage their care as palliative care to telling them at the end of that same decade that they had a lifelong chronic viral infection that we were going to treat and manage. And I think we're headed to perhaps as transformational a decade in the 2020s in genomic medicine. State cancer registries, I think, are a model for multi-agency funding, and we already heard from Terry and Eric that the NHGRI is not going to be able to float this whole thing, but there are other institutions that would join in. The expectations would be to reach the whole population, to engage new patients and providers and researchers, and to re-engage participants from the All of Us project and from maybe direct-to-consumer testing. And I think we'd be able to create a network that could define standards for consenting, data collection, clinical trials implementation through this structure. And that standard defining could either be by design or default. There could either be standard setting as part of the mandate, or it could just be that this is what this network's doing, this is what we should follow. And with that, I'll end. Thank you.
So good morning. My name is Denise Dillard. I am a Nupiaq Eskimo from Anchorage, Alaska. So I'm the Director of Research for South Central Foundation, which is a large tribal health organization in Anchorage, Alaska. So I'm going to be talking a little bit about this issue from the tribal health perspective. And I'm going to start with kind of some of the barriers, but then also talk a little bit about some of the opportunities. So this slide shows the average per capita expenditures allocated to different types of federal healthcare systems. And you'll see kind of way towards the right there is the Indian Health Service budget. So it is more than, it's actually half of like the VA, other federal healthcare systems. And so this is a very under-resourced setting, and my passion about this topic is really to make sure that genomic medicine doesn't become another way that health disparities are actually exacerbated instead of ameliorated. So I think one of my key messages is that I think we really need to pay attention to resources. And then there's all the challenges of providing care in places like Alaska, which is somewhat unique, but there are also rural underserved people kind of across across the nation. And so how are you going to make sure that advances get out to rural Alaska, places that are only accessible by plane? So in terms of barriers, one barrier is the lack of applicable research findings. And for Alaska Native American Indian people, unfortunately, there has been perceived harm that has been done through genetic research. And so I do have one study that's specific to Alaska, which is up on the top, which was actually a genetic study done at the request of the tribe, but it ended up being a very stigmatizing study, resulted in a bonds dropping, but they described the tribe actually that I come from. We don't see Eskimos surviving until then, which is 2010 or 2015. This is not a collection of individual alcoholics, but a society which is alcoholic and therefore facing extinction. And then I'm assuming many people have heard about the Havasupai case, but that is a case where the tribe requested genetic research about diabetes, and with the broad data sharing, with the data, instead things like inbreeding and schizophrenia were looked at, which resulted in a large lawsuit. So these are some of the very critical barriers to overcome. But I do want to kind of talk about the solutions. And there are more and more tribes taking over provision of their own healthcare system in an effort to really respond better to their individual tribes. And there are tribes engaging in genetic research. So I know South Central Foundation is part of the Northwest Alaskan Pharmacogenetic Research Network, which has looked at variants known to affect responses to medications like warfarin, tamoxifen. And then this is more recent. The Navajo Nation has actually reconsidered its ban on genetic research, and actually there is a data sharing agreement that has been negotiated. I think in our engagement with our stakeholders and our patients, they really very much want to benefit from genomic medicine like other people if there's appropriate protections in place, and those do include paying attention to the possibility of communal harms as well as potential risks to family members. I also want to say that I think that the tribal health system is actually a pretty unique opportunity to really take a look at phenotypes, because many of the electronic health records really have information on people from birth on. So there are some really unique opportunities there. And let's see, I think once again, just really to kind of end on the need for the infusion of infrastructure. So we've done this pharmacogenetic research up in Alaska, but we have one genetic counselor serving hundreds of thousands of patients. And so actually there hasn't really much been implemented as a result of the research and some of the many things that we've heard here earlier. Providers aren't set up to do it. Patients are in different varying stages of kind of understanding of genetics. And then I also just want to say that really looking at this issue from a public health perspective, one of the things that we've also heard from our stakeholders, our patients, is that they support genomic medicine, but they really don't want it to fund care for a select few at the expense of the rest of the public health issues. And I'll end at that point.
Hi, I'm Casey Overby Taylor, and just to get started, my background is in biomedical informatics, and so when we were asked the question of what's needed to get genomics into medicine and health, I first started by asking my genomics colleagues, like what would be a good driving use case for this, and if we were to return secondary findings from clinical genomic testing. And so I was really happy to hear that Heidi brought up expanded carrier screening as an example and used the term piggyback testing, because this is this was a very nice use case to explore a bit further. And so as a naive searcher, I then looked at ClinGen actionability workgroup website to see what, if somebody was getting carrier screening, what kind of result might be relevant for that couple if they were to get secondary results. And so I was able to bring up this example. If there were a pathogenic variant in F11, then this would lead to complications and bleeding complications during pregnancy. This could lead to possible death, and there is a highly effective intervention at low risk. And so this is something that hopefully a computer would be able to identify and potentially prioritize for a patient that you understand what their reasoning is for going in for treatment. And so just thinking about this further, the big problem that I see and has been brought up previously is that the benefits of communicating this genetic risk for these kinds of severe outcomes on clinical practice is unclear. And the solution that I'm proposing, based upon the fact that networks such as eMERGE are exploring relatively consistent ways of getting genetic testing, there are often tailored and multifaceted ways for their implementation strategies across the different sites. And so how we deliver the information needs to be customized in that way in order for us to be able to see changes in clinical practice. And so what I mean more specifically by tailored and multifaceted is the modalities for delivering information. This is both to clinicians and patients. And so in addition to the EHR, where decision support can be useful, when it comes to decisions regarding patient values that are incorporated, there might be a phone call, there might be information for the patient to educate themselves as well. And so different modalities can be leveraged there. And also health literacy is very important when considering how the information is presented. So health literacy, genetic literacy, numeracy, all of this may influence what and how information is presented. And then finally, what is being offered, or what kind of guidance is available, is also very important. So is it a treatment choice, or is it more increased monitoring, and so on? And so the main reason for considering this scenario was to support for broad dissemination. And so this is the point of the asterisk next to the solution. And so when we think about NHGRI being able to support this, they have these, NHGRI has provided support for several large network institutions, and these are examples where there's both analytic validity and clinical validity to a certain extent that's been achieved by providing a platform for all of the sites to conduct clinical genomic sequencing and returning them. There's also support for ClinGen, which is providing assessment of outcome severity and intervention effectiveness. And we're getting to the point where we're doing comparative effectiveness research based upon this. In order to achieve broad dissemination, we needed to consider scenarios that fit within current practice. And so this includes these piggyback testing scenarios. Also, there's a need for flexible access to genetic information, while NHGRI is also supporting several information resources that go to both clinicians and patients. Being able to provide a venue for pulling them into decision support tools, into these different modalities, as I mentioned, is also important. And then finally, in order to achieve broad dissemination, we need to establish not only whether or not something's effective enough, but also the mechanism by which that the strategy is working. And by understanding what is that key mechanism, and with awareness of the value of genetics being one potential mechanism, by knowing this, that is disseminatable information to help sites themselves to be able to answer this question, to know what is the strategy that's appropriate for the site. Thank you.
Hi, I'm Latrice Landry. I'm a clinical molecular geneticist and genetic epidemiologist, and I focus on the equitable translation of genomic medicine. And particularly why my research focuses in that area is because I'm concerned that the current disparities will only be exacerbated by our successful implementation of genomic medicine if we don't address current challenges now. And these challenges or disparities include high rates of morbidity and mortality, including higher rates of poor birth outcomes in certain populations. And in particular, the poor birth outcomes. You think about it, it's suggested that African American women experience poor birth outcomes at 300 times the rate of their white counterparts. Think about that. 300 times more likely. That's an injustice. And it's an injustice and an inequality, it's an inequity, and it's a disparity that deserves our research. And when we think about genetics research, we can ask ourselves the question, what do we know? And the truth is we don't know a lot. What we've shown and others have shown is that when you look at genetic research, depending on the databases you use, you see about 71% of all genetics research is focused on populations of European ancestry. If we juxtapose that to the US population, which is about 65% European ancestry, and then go on to look at the world population, which is only about 13% European ancestry, we have quite the discordance between who we're studying, the evidence base that we're building for genomic medicine, and the populations that we intend to serve. And when we think about the lack of data, and I know there was an issue about whether we really have a lack of information, but I actually think in the case of diverse populations, we are suffering from a lack of information, and that means a lack of evidence. And when we think about that and its implications for genetic testing, which is our key vehicle for genomic medicine, we can think about these 5 different areas in which we expect to see an impact. And that is, we can have an absence of certain biomarkers for key indications because we haven't discovered them in those populations. We haven't discovered them in the populations that have a higher frequency of those markers. Additionally, we can have unknown pharmacogenomics results, knowing that whether they're efficacious in all populations. We can also not know exactly if all pharmacogenomics are efficacious or safe. We can have unvalidated risk in all populations, so we could have risk calculations or predictions that are not validated for all of our populations. And we can have wrong or unclear diagnosis in some populations. And the reality is actually research has shown evidence of some of these in all of these categories, with misdiagnosis of cardiomyopathy in African Americans, which was published a few years ago, as well as the question about pharmacogenomics being efficacious in all populations, with example by warfarin dosing. And also a paper we published last year about lower detection rates and higher rates of inconclusive results for cardiomyopathy for underrepresented minorities. The reality is that when it comes to whether our genetic tests are working for all, we can't say that they are. And so I argue that the first priority, and perhaps the only priority until we get it right, for accelerating or being on the frontier of genomic medicine is building the infrastructure that will allow a population-sensitive workflow for genomic testing. Right now, we have a lot of questions about whether a specific test will be effective in any one patient. We also have questions about how we should dose, and we also have a question about how do we sift through all of the information to get to the right answer. And the reality is that this population-sensitive clinical genomics workflow should be enabled by a learning knowledge base that is annotated at the population level. And it has to be a learning knowledge base because right now we don't have all the answers. But the reality is that building this knowledge base that's annotated by the population level, that would be accessible for clinical decision support in the electronic health record. If we had a system like that or a knowledge base that we could use that way, then we could also have a process that evaluates standards and best practices across diverse populations that allows optimal validity and utility for our genomic tests. And we can decide, once we've collected all the information and once we're all using this type of approach and process and in this learning system, we can also decide whether a specific test is useful for all populations or an individual population, and then follow up with standards and policies for how to implement it across diverse populations.
Thank you. All right. A lot to discuss. So I'm going to kick off the discussion knowing that our participants out here are bursting at the seams to ask questions and share their ideas. So to get us started, I think we've had great presentations today, and what Terry spoke about, that slide showing the difference in the percentage of what, in terms of human genome research, is being done here at NHGRI compared to other institutions and the change over time. I think that's really going to stick with me for a long time. And thinking of that with the different ideas that you all have presented, who are the right partners to be doing this type of work? You each gave different types of examples. And when I say partners, I think that can either be other institutes, it could be other agencies, or even at the community level. Who do we need to do this with? I think that's something that is an important piece in terms of, we all know that saying, if you want to go fast, go alone, and if you want to go far, go together. Well, what does that togetherness look like for each of the different ideas that you presented? No.
I actually don't think there's anyone that should be excluded. I mean, I think the work that is in front of us requires academia and industry, government working together side by side, along with the patients that we help to serve. And so I think that having focus groups and patient groups be partners in how we design and look forward to sort of implementing genomic medicine is important. Along with, and we often think about patients as being the end users, but I think also physicians and clinicians are part of are part of the industry, or people that we're serving as well. And so I think that together it is required, but I think it requires all of us, not to reference the All of Us study, but yeah.
So I guess in terms of how we make genomic information accessible broadly, and understanding the value of genomics, I think that there's an opportunity for a value framework based upon different stakeholders. So the patient, the provider, the healthcare organization itself. And in terms of delivering information, there's opportunities for groups you may not think about initially around genomics, like the medical librarians, to help with managing knowledge, and also health IT professionals are particularly important when it comes to how you deliver information as well.
So the thoughts I would add is, I think obviously Indian Health Service is one kind of partner. Individual tribes, though, are taking over more and more of their own healthcare. So having time for that community engagement and really building those partnerships, I think, is really, really critical. And then I think other funding agencies like ARC, PCORI, those are all important partners too.
So I think if you set up the infrastructure and you invite people in, they'll be able to potentially ask and answer questions that are important to them that we might not even imagine. So a statewide learning health system in Connecticut, I could see us easily partnering with the insurance agencies that have a home there for questions that they might want to ask and answer, and get funding for that unit in that way. And in other states or other areas, the opportunities might be different. So state cancer registries were started in 1935. and initially funded locally, now funded through NCI, CDC, and other entities. So I think it's a matter of building the infrastructure that invites people in and allows them to participate and bring money.
Thank you. A trend that we see in a lot of places is people taking over or more ownership of their own health, whether that is the individual who now has access to potentially more information online and making decisions. My background in my world is maternal and child health. So recently there was an article about people refusing ultrasound during pregnancy and making those choices. And then we talk about all the way up to populations really kind of taking over the research that's being done in their communities. And so I have that on one part of my mind. And then I think of something that Latrice had emailed with me a little bit about in terms of at the end of the day, like, is it really okay if we see validity and utility just in some patients but not all? Is it okay just to focus on where there's interest and data and where things are going well and hope the net will slowly get bigger and bigger? Or is there a responsibility to really capture more who isn't being pulled in or who is maybe taking over your own healthcare? Could look like a lot of different things. It could look like more inclusion and more participation and more voice. It can also look like taking a step back and actually not what some might say showing up or saying, looking at other areas. So is that okay? Is it okay for everyone just to kind of make their own decisions, or are we really looking for more participation, more inclusion, or is it more about the decision being made, that it isn't just you're accidentally in or you're accidentally out? I know that was a lot of different ideas coming together at once, but I'm actually going to start over here.
So I think part of having patients and communities engaged allows those patients and communities to tell us what their agenda is and what are their priorities. So I think you need to do that, but you also need to have use cases that are easy to understand by people outside this room and can communicate sort of the value of genomics. So I think there has to be sort of expert set priorities as well as community set priorities. I think you have to do both.
So I think when it comes to really thinking about kind of population health, I know at least where I think many tribes are right now is I think there is a desire to pay attention to kind of the health of the whole population given multiple areas of disparity. And genomic medicine may or may not be able to address some of those disparities. But I also think people don't really want to be left behind either and to get further behind. So I think it's really both, and I think there are good examples out there of how to engage diverse groups in genetic research where it feels like it's of mutual benefit, and really building upon those examples, expanding funding, and building on those already existing networks would be a good strategy.
So I heard a lot in what you were saying. I guess the evidence base and how it's evolving is one thing, to be more inclusive, but also I guess I think a lot about access. So mechanism of access, and so more and more people are using cell phones and text messaging, and so there may be ways to communicate information so that it's broadly accessible. So that's one thing. And you're right, a lot of people bring up All of Us as an example project where there are more diverse patients who are being recruited into projects, into research, and contributing their data. So the evidence base will continue to increase, but I guess there need to be mechanisms to allow for that kind of learning to occur beyond these research projects. And I didn't offer a solution there, but maybe solutions that Mike brought up might be one option.
So when I first started training in clinical genomics, people would often use the term early adopters, and you would see in our research studies that a certain type of person was really interested in getting their whole genome sequenced. And I think that was fine for the time because it was very early. But the reality is, for very few parts of medicine, maybe elective medicine, plastic surgery, we can afford to have people who are electing into it, who choose and are early adopters and are sort of a part of the system. But with genomic medicine, we're talking about a transformation in how we administer medicine. And it includes cutting-edge therapies that are supposed to be more effective, reduce side effects. It includes diagnostics. It includes prediction of risk. And so it's just not reasonable to have that be a self-selection, right? We can't just limit that to the people who are early adopters. We can't afford to say, well, certain communities aren't engaging and therefore they'll be left out. I think that the reality is we have to find ways to engage communities, to bring people in. And if we're not doing that, then we need to change our strategies, because I think that the issue of validity and utility is something we have because when we were doing research, we didn't do a good job of engaging communities to bring diverse people into our research. So we can't lean on that as we are now implementing in clinical care to say the same thing. We're not going to engage and we're going to allow people to be left out.
Great, thank you. Well, so now I'd like to open it up to the members in the room. Any questions, comments?
So I thought these presentations were really great, and I think I heard one word that I think we should keep in mind, and that's responsibility. I think it is the responsibility of those doing the research and doing the clinical care to engage diverse communities. It's not going to happen by chance. It really is an effort that needs to happen, whether it's resources or different ways. I think that, all patients are not the same. All patients are not seekers. Some patients are just patients. I think of my mom as a different kind of patient than I am, that type of thing. So I think that it really takes an effort, and it's the responsibility of those doing the genomic health, because it is a healthcare advantage to be a seeker in this case.
What does the audience think here about opportunities that you could frame? Oh, is this not working? Yeah, it is. Okay. Frame some grand challenges from some of these wonderful presentations we've heard. Issues have been raised. Some opportunities have been proposed. What could the Institute do that would be at the level of a grand challenge that people would say, wow, that's an important problem, we've got to solve it, and it would be awesome to be solved? Start in the back. I think the hands are up first.
Yeah. To me, there were a couple of things that came out of these presentations that were really important that also jive with the idea of using this information over time. And that is the idea of how do we get this data to not only persist, but also follow patients around in the healthcare system, because Geisinger is a bit of an exception in the sense that our population has very little in and out migration, and so we literally can provide cradle to grave. But we are hardly representative of the United States healthcare system, and we have difficulty even moving simple data around, much less having genomics travel with people. And Mike touched on his presentation about health information exchanges, which is one possible scenario, but I think the bigger idea is what would a safe harbor look like, where, who would be the trusted entity to manage genomic data, to deal with the concerns about privacy and potential for discrimination, to make sure that there's fair and equitable use of the data, to make sure that data voids are being filled in an intentional way, and to develop the interfaces that would allow that information with appropriate knowledge attached to it to be given to patients and to providers to actually improve care and capture outcomes. Now that is a grand challenge, but I think that's what you asked for. But to me, all of the points that were brought up in the different conversations are reflected within that. And I think the final idea is the point that there are populations that are going to need to have ownership of this in a different way. And that type of a safe harbor needs to accommodate, especially at risk populations as well. So to me, that would be the grand challenge.
Jeff, Jeff, did you have your hand up? No? Okay. Who else had their hand up? Yes, please.
So I really appreciated this set of talks because I feel like it's recalling NHGRI to its important roots as an institute which has specific funding for LC research and the importance of the LC mission. And when we think about clinical value or return of value, we've already talked today about the complexity of that value outside of economics. When we think about genomic information, about people using genomic information to make decisions that are best for themselves or best support their own values. And so I like this reminder of that essential responsibility that we have. I also really liked hearing the calls for creating, for lack of better description, metadata harmonization that would allow for community-driven research to be done on these data, to empower communities themselves to ask and interrogate the data, to come back with answers that are meaningful to them as a community, which again may not be about economic value, although they could be, but they could have also additional other values as we see with individual level genetic information being used to create clinical value in its broadest definition. So I just wanted to highlight those 2 points.
I think that we are suffering from an ability to really think about best practices in this space, and especially as it means for creating standards for generalizability of any individual genetic service, but also the utility across populations. So what is the requirement? What is the threshold we need to be at? Is it sufficient to say, I have a test, I've only validated it in a certain population, therefore my training set didn't include these people, I'm going to exclude these people from having that service. And I think that right now it would be nice to have a challenge from NHGRI that really sort of challenge people to come up with best practices so that in a community it could be evaluated. So there could be feedback responses about sort of how people feel about certain about the performance across populations. I mean, one of the other things I've heard before is people would love to have a data set, if you will, that they can test their products on. And I think that part of what we need right now is an ability or a forum to convene and really look and discuss, but also have data we can evaluate to see about our individual tools that we are creating, because infrastructure seems to come up in everyone's talk.
So I thought there were 2 really interesting cases that were brought up. So one being the study of the alcoholism in Native Americans, and then the second, the dramatic difference, between African American and European Americans in terms of adverse outcomes during pregnancy. And I think there is a danger, and that some may see as an opportunity, but there is this present danger that you'd say, okay, well, there's a 300 times higher risk of African American women having adverse outcomes. Is that genetic? And then people might use that the data in a genetic study that would result in some sort of discrimination against African American women, saying, okay, well you're African American, so therefore you're genetically predisposed to having an adverse outcome during pregnancy, so therefore your healthcare cost is much higher, or you won't get coverage. So I think there's we want to have a lot more diversity in terms of sampling and knowledge bases of genomics, but somehow we need a framework such that that data is not used in a discriminatory way, in cases such as these.
Since I have the mic, I'm going to chime in before handing it down the line. I think another way of framing that, earlier we heard about, the idea of a need of a culture shift. I think there's a need for a culture shift here that a patient's or a population's problem isn't necessarily their problem, but really the system that we've created was not created for them and does not really even take into account that there may need to be some shifts. So just trying to add a bit more of that language because you're absolutely right, that's where we have the language for what you are saying in terms of we found this in this population, that must mean there's something wrong with them, whether at a genetic level, oftentimes at a socioeconomic level, that's where the problem is, as opposed to saying, wow, our system that we've created really hasn't served this group that is still a part of our system.
Yeah, I think it highlights sort of the conversation about LC research and the importance of that. And one of the questions was, should NHGRI be involved in education? Absolutely. I think we still suffer from a fundamental understanding of epidemiology and statistics, and so finding spurious associations is something that I think we need to continue to educate people about. But I think also we need to, when we think about knowledge bases, I was talking about annotating things on a population level, but because we only had 5 minutes, I didn't get into what define population level or what annotation looks like. And I think that's the beauty of a learning knowledge base. And maybe the knowledge base is developed, as Mark mentioned, they developed Geisinger or sort of before they launched Prime Time. They spent years, or a couple of years, developing what they wanted to do. And so I think that before associations and sort of decisions or things get put out there, it's appropriate to develop a learning knowledge base and continue to learn from it, understanding that how we annotate populations isn't specifically on self-described race or geographic location, but that really we need to be breaking this down to more granular levels, because we can actually parse that out, right? We can actually look to see if any one population group, if there are other variables that determine or that are carrying that association, we can, sort of look at that.
So I was just going to say I think there is an opportunity to study, to first identify patients who are benefiting differently from healthcare and who might benefit from genetics, and finding out what are the characteristics of those populations, and coming up with a model for how we might accelerate recruitment of those individuals into research, and so maybe framing the problems around where the differences currently exist, and how to address how to reduce the gap right now between care with the use of genetics.
So I just wanted to kind of add on to a couple comments about the importance of LC research, but then also using the results of LC research to really design how studies and efforts are deployed. I know I sit on the Tribal Health Work Group for the All of Us initiative, and I know one of the challenges is the open data sharing and also consenting for kind of unknown research kind of in the future, which is really not what the LC research says in terms of work with American Indian and Alaska Native communities. But I also, as a researcher, I also get the need for multiple people to access data. So I really I hear the grand challenge of the, where is the safe harbor kind of entity, and where might that be? I also just want to add in the importance, in addition to genetics, for kind of environment to always be a part of important part of the discussion. So I know, for instance, in Alaska, there's a ton of variability in the Native community in terms of diet and where they live, and different types of exposures. And I think for us to keep those things in mind is also really critical.
So a grand challenge that I'd like to see is maybe one with 4 or 5 bullet points under it, and that would be, implement these things, and then underneath them are things that there are recommendations and tools and ability to implement things that just aren't getting done. So women diagnosed with ovarian cancer, 15% BRCA positive. The recommendation of the NCCN is to do it without family history, just to offer this test. There's been 2 academic centers that have published their efforts to do better implementation and drove up that implementation within their large healthcare organization. But your state, whatever state you're in, has all the data on all the women that have ovarian cancer. We need to find a way to offer each and every one of them that chance, and then to do the right follow-up. And that's an implementation challenge that's very discrete and very doable. Another one in reference to what Dan asked earlier, your state probably also tracks, I know Connecticut does, everyone with early heart disease. You could easily set a cutoff of 45 or 50 years of age, say we want everyone in the state to have, or in whatever locale, to have that testing done. So you could essentially have a grand challenge, when are we going to get to these implementations, 1, 2, 3? And it's not, let's implement pharmacogenomics for everybody in every scenario that CPIC offers, but very discrete and very doable. And I think we'd learn a lot if we did that and then tracked the outcomes.
Right. Okay, we've got some audience here. Tony.
Well, Mike, the statewide idea is a really good one, and based on newborn screening, it would, if you could find a way to do it, like you said, the implementation is the problem. Everybody's involved in that. Your newborn screening occurs sometime within the first 48 hours of every child that's born. So that eliminates sort of the disparities and issues with people not being involved. The hard thing is, how would you do this for genomic medicine? Of course, the states are challenged already with even the newborn screening program, but I like the idea of having that being a basis. So how do you get from where we are now, where there are some institutions and systems that are doing it well in some states, but it's not statewide, to go from there to try to find out the best practices for a few there's nothing easy, but low-hanging fruit, what should you call it, to move toward implementing what's done in a system to a state. And maybe, like you said, a state-by-state basis, they could figure that out. What the NHGRI could do to help with that might be to set up programs to see how those can be implemented from systems to a state. Anyway, I like the idea about newborn screening as a model.
Before handing over, if you wanted to respond to that. We keep coming back to newborn screening, and I'd be remiss not to bring this up as the director of the nation's Newborn Screening Educational Resource Center. Yes, every kid gets newborn screening. That newborn screening looks different state to state, and that is a space where we have seen great improvement in the disparities, but it does sometimes feel like a swinging pendulum in terms of as more complex conditions are added to panels in certain states. Other states are saying, what are you talking about? We barely can still make sure that kids stay on formula for PKU. So sorry to burst the bubble that newborn screening is, it's great, but there's still some of the same issues that are coming up here.
So I really like Mike's idea of statewide systems, and one of the grand challenges that could be taken up is cascade screening of tier 1 under that infrastructure. I've thought a lot about FH, for example, and how difficult it is to cascade screening because our healthcare system is fragmented, and as Mark pointed out, the yield of that is very low. If you look at the Netherlands, where they have a statewide system, cascade screening has been spectacularly successful. And I think the only way we can implement such a system is if we have a statewide, work with the Department of Health, have healthcare exchanges, have registries. So I think it'd be a wonderful low-hanging fruit to take that up as a grand challenge using the system. And the other thing I wanted to mention is this issue of engaging with Native Americans and minorities. I think that could be also under that umbrella, extending the FQHC to those communities.
As a general internist who sees about a dozen very medically complex, very diverse, very high-need patients in a morning, I want to understand what your ideas are for integrating this into my practice. So we already know some things. I've heard a lot of people saying, we need to get more stuff to the docs. The doc should be responsible for this. Don't shy away from it. Woman up. And for me, I understand, like, if somebody has an allergy, there's an allergy tab. If there's medication interactions, I can't sign off on a medication because the system says, are you sure you want to do this? And I have to click and say, yes, I'm sure I want to give it, even though it says the person's allergic. However, if there's PGX testing, the results can't be looked to, according to the FDA, if I understand, the pharmacogenomic test results can't be linked to what I can and can't do. I don't know where to get that information. It's going to be stored somewhere. Somebody other than me is going to be doing the testing. The responses are in a way that I don't understand. And I have 10 things to do with my patient already. And now I'm expected to do right by my patient with this information when I don't have time to do it and be liable for it. So I'm really interested in this part where it says integrate genomics into everyday clinical practice.
So I was just going to say, in some of my research, I've found just doing experiments that how you present information can influence the confidence that a clinician has in their decision making. And so careful consideration in what's presented and how it's presented is important, just as you've highlighted all of the issues. And so one area that may help to facilitate implementing correctly within your institution is leveraging some of these oversight committees that are already making decisions around pharmacy and therapeutics committee. They could be asked for input on what's appropriate, and perhaps other groups could or libraries could participate in the process of presenting what might be a good option, but having it vetted by somebody who has a role and a clinical specialty on what is actually delivered to a clinician might help with this process. And so if there were infrastructure to help facilitate doing that, that could be another area.
Back before everybody had a chief informatics officer, you used to have the computer scientist, physician who would sort of build their own homegrown information system for their department or their division. And they had lots of control, and they would put clinical decision support or flags or warnings for whatever they thought was important by consulting whoever was required to do that just for that department or division or hospital. I think now we have a lot more sophisticated ways of doing that, and we also have a whole science on physician fatigue. And I think it does cause us to think about informatics research and how we might implement this. And I often find myself telling people that informatics research is a part of implementation science, and sort of what we're getting at is how do we sort of test the implementation of genomic testing and the interpretation in a electronic health record system. I think this is important to do. I think that if it were to be a grand challenge, and not that that's not grand by itself, if it were to be a grand challenge, then we might have partnered systems, right? So you'd have to have a shared or a similar EHR, but you'd have, for instance, a major academic center partner with a smaller community hospital, so that we can get through the equity challenges. And the challenge would be, how do you implement the same thing in this major academic center as you do in this smaller community hospital, given that the electronic health record isn't the rate limiting step. So they have EHR, maybe you both have Epic, and then you partner together to sort of bring everyone up to scale. I think that would be a grand challenge. And there's a lot of research and practice and best practices can be learned from doing that.
So I'm not a bioinformaticist, so I'll tell you a people solution that I think works. So I was at Geisinger until a year and a half ago, and when we set up that return of results, we said repeatedly that we wanted to set it up so that every primary care provider would have the tools and resources to give the result back if they want and to manage the care going forward. And so we set up all these CME and other resources for the primary care providers. And it turned out that the uptake of the CMEs, the highest user was the CEO of the organization, and primary care providers, although it was easy and available, didn't have time or bandwidth to necessarily do that, is what they told us. And the primary care providers repeatedly said, you're the expert, you take care of this. So, I think that we need a human resource where primary care providers can say, I need to have you follow up on this. And if you set it up right over a large enough organization, you would have a core team of clinical geneticists, genetic counselors, maybe advanced practitioners that would be able to manage that as a service for when you get confronted with a result that you're interested in the patient getting the best care for, but you don't have time to necessarily manage that. So in addition to all the bioinformatics stuff, I think a human resource, well-placed and well-developed, could be really useful in big systems.
So we're getting close to the end. We had a couple hands back here. Wait, was it you first? Go ahead, Colleen, quickly.
Thanks. I think it's been a really rich and interesting discussion, and the thing that I keep thinking when I think about integrating what everyone has said and rereading the theme into a grand challenge is that, we need to try a bunch of these things. Like, I can imagine a grand challenge being, a given institution with broad engagement from patient stakeholders, primary care. It's not just a grant that's written by the genomics folks. The CTO is involved, all of that, and different institutions are trying different mixes of solutions, whether it's EMR integration combined with an e-consult service like Heidi described, combined with some sort of triage that decides when you use that limited, not very scalable human resource. I think that's what comes to mind for me, which isn't specific enough because each of those are going to have to be their own version of the system part of systems to integrate into everyday clinical care.
Mark?
Yeah, one comment on this thread and then a question for the group as a whole. So Casey, of course, is very modest and didn't point out that there's been a tremendous amount of publication through Emerge and Ignite and other of the NHGRI-funded consortia networks on how to use informatics solutions to try and improve the care, including a lot of engagement with end users, which Casey has led as co-chair of the Emerge Electronic Health Record Working Group. So I don't think we should assume that there's a lack of evidence about how to do it. There is certainly a lack of evidence on how best to implement, and I think we're getting to the point where using implementation guides, which I agree with Mike, has to be connected with the human resource as well, that can do it. And I think the example articles that I presented in my presentation talk very candidly about what is needed to successfully implement. And those are groups that have actually done it. And so I think we have examples of how this can be done, so we shouldn't look at this as being an impossibility. Now, the question that I had for the group relates to the issue of equity and disparity, which I think is a critical issue. One of the examples that I use of a grand opportunity and challenge that was successfully met was children's cancer back in the 50s, when it was a uniformly fatal disease. And many of the same issues that we deal with in genomics, they dealt with there. Rare disease, no one institution had enough patients to really study. So the decision was made at that time to form, I think, what was originally called the Children's Cancer Study Group and is now the Children's Oncology Group, where essentially 85 to 90% of kids with cancer in this country are treated on protocol, where they, and that information is collected centrally, and they use that. And so we've gone from an incurable disease to one where 80 to 85% of kids achieve cure, which is spectacular over that short time frame. So I think that's a model that could be used. But the question for the group is, has that group specifically dealt with access to vulnerable communities in terms of, do they have the same access to those clinical trials and protocols in the Indian Health Service or in inner cities that other groups have? If so, we could learn from that. If not, then we've got a systematic problem that needs to continue to be addressed.
Brief response to a not brief question?
So in terms of clinical trials, there's very low participation among tribal people. And I think, some of it just goes to kind of some of the challenges, the remoteness of some of the locations, et cetera. But also just, once again, this kind of distrust of research and kind of being experimented on. But, it does also create these issues of, we don't have the same knowledge in the population.
And 54 seconds left. So I would say it prior in doing my clinical fellowship, I worked with the FDA, and one of the challenges they said in trying to engaging pharma companies and having more diversity in their clinical trials was that their infrastructure wasn't set up that way. So they partner with major academic institutions, and whoever comes into the study is whoever is being seen at those institutions. And so I think this infrastructure is probably going to be a key theme, but the infrastructure, even for that, in clinical trials, needs a transformative shift to be able to capture those communities that aren't already in the system.
A closing question from Heidi.
One last grand challenge is, how do we get genetics at the top of EPIC's to-do list?
Good luck.
You want any closing comment?
All right. Well, with that, it just turned red, so I will close the comments and we can go off to lunch. But thank you so much to our panelists. I think this was a great way to kick off the rest of the discussion, and to all of you. Thank you.
So thank you, everyone. We have an hour for lunch. For those of you who ordered, lunches should be out in the break room right outside. And if any of you need ideas for other places to go, there are a couple of cafes around the lake that we can point you in the right direction of. So we'll see everyone back here in an hour at 1:20. Thanks, everyone.
So nice to meet you. So great to meet you. We've seen each other, yes. And
That's good seeing you.
I heard your voice multiple times.
Great job.
I'm going to insert the slides